Morning, everybody. And you're absolutely right. Please, if I say something and you want to ask a question, just interrupt me. And I really so we set up today as kind of a Pathways 101. So I'm going to give you a lot of information, but then hopefully we'll have most of our time for questions and discussion. So lots of time built in for that. So I'm going to go right into the presentation on the Pathways Community Hub model. And my slides aren't moving. Oh, there they. So hopefully you're seeing a slide that has risk on it. And this model really is all, if we had to define it in one word, it would be risk. It's knowing who the most at-risk people are in the community that you need to serve. Once you find them, it's doing a comprehensive risk assessment and then tracking that risk through risk reduction. So we'll come back to that over and over again. And I know you're all well versed on social determinants of health, but just to again make the point, if we're trying to make a change in a clinical outcome, and I have for the example here, infant mortality rate, we may get a 20% improvement if we just focus on healthcare issues. We really have to look underneath the iceberg and look at all of the other factors that come into play. So I threw up the definition of care coordination from the Agency for Healthcare Research and Quality. And just to read the highlighted area, care coordination is the deliberate organization of patient care activities between two or more participants, and I love how they put in parentheses, including the patient, involved in the patient's care to facilitate the appropriate delivery of healthcare services. So in just that little snippet, you can see that the definition is very healthcare centric. It's very much focused on what's happening in the healthcare world. And so what I'd like to offer here is that this is a model that's actually dealing with community-based care coordination. So what I just described is kind of that middle light blue oval of care coordination, more healthcare based. And then we have direct services on the left and community-based care coordination, which is what I'm going to be focusing on today. And so when I use the term a community care coordinator, very often that's somebody like a community health worker, but it could also be a public health nurse or a behavioral health case manager or a birth to 3 home visitor. It doesn't matter so much what their definition is, it's more that they're spending their time out in people's homes, in the community, not waiting for folks to come to them. So why do we need care coordination? Well, just a few facts here. This is from the Robert Wood Johnson Foundation. More than half of patients can't state their diagnosis when they leave the hospital. More than a third can't explain their medications. Less than a half saw a primary care physician within 2 weeks of leaving the hospital. And 1 in 5 has an adverse event when they transition from hospital to home, and 2 out of 3 events are related to prescriptions. So, and I'm just going to ask if everyone could just mute themselves. I'm just getting a little feedback, so just make sure you're on mute. So definitely we're not doing great with our transitions certainly from the hospital back to the community. But when they ask physicians specifically, what kind of problems do they have when they try to coordinate care? They do pretty well with family members and other healthcare folks, but when they get into schools or employers or non-hospital institutions, things start to fall apart. So in another white paper that the Agency for Healthcare Research and Quality put out, they came to the conclusion that connections between primary care and community services simply are absent or highly fragmented and disorganized. So that's kind of the state of where we're starting from. My story actually begins in Alaska. This is a picture of Kotzebue, Alaska in the springtime. This is probably April or May. And my husband and I are both physicians, and we went to Alaska after our internship year of training and spent 3 years in a very, very rural Alaska. And that was our first experience with community health workers. Had never heard the term before until we landed there, and really began to realize how valuable they were in providing information that we had no access to. And when we landed back in Ohio, we took a detour to Baltimore to do our residency training, but landed back in Ohio. It was really a hard decision of should we pursue this model or not? Because what we learned from our time in Baltimore was that most programs that use community health workers or community-based care coordinators often are grant funded, and when the funding goes away, they're the first ones to be let go. So as we made the decision to move forward and to set up the Community Health Access Project, or CHAP as I'll refer to, it was really with the decision to make sure that community health workers had a long-term job potential, that they wouldn't be trained and then, 5 years later looking for something new to do. So we went out into the community. We did some hot spotting before it was the cool thing to do. We had mapped out where all of the bad birth outcomes happened in our county. We went to those areas where the low birth weight rates were about 23% in certain census tracts. We found community members that were already making a difference in the community. We hired them, we developed college-level training for them to go through, and we sent them out. And in the meantime, kind of simultaneously, we started working on certification for community health workers in Ohio. So Ohio was the second state to actually have certification, and ours is unique in that it's the only state that has it under the Ohio Board of Nursing. So I just put that up there in case you're interested. That's a whole nother conversation, but if you go to the Board of Nursing website, you can kind of see what the requirements are in Ohio for that. Well, we hired these people, we trained them with really extensive training, we sent them out in the communities where we knew the outcomes were really bad, and we looked at our data a year later and we hadn't budged anything. It was really disappointing. In reality, looking backwards, it was very naive to think we could add one more person to the chaotic mix of the community and think we were going to bring about this big change. But at the time, it seemed like that would make a pretty profound difference. We knew we needed a better strategy. So let me kind of set the framework here of what a typical family at risk would look like for a community health worker or another community-based care coordinator. Let's assume we start with Marcus, who is a 6-year-old. He was just seen in the emergency department again for an asthma exacerbation, and fortunately it was the same ER doctor as the time before, who realized that everything that she said hadn't been followed up on. So no follow-up with the primary care pediatrician, no asthma action plan, no medications. And as that community health worker goes into the home and tries to, provide asthma education, she finds that Marcus's mom is pregnant, has been very ill. She has lost her job, and she can no longer pay for rent to stay where they're living. The only possibility is to move across town with Marisol's mom, who's living in a 1-bedroom apartment and is a pack-and-a-half-a-day smoker and was just diagnosed with type 2 diabetes. And I will tell you, when I use an example like this, when I train community health workers, they go, "Why'd you pick such an easy family?" I'm like, it's overwhelming for me, but they list off there's nobody in jail, no substance abuse. So in their eyes, this is an easy family to deal with. The reality is, for most communities, there's a lot of community-based care coordination, but it's very siloed and fragmented. So this family could easily have 3 to 5 care coordinators coming into their home offering very specific information. Mom could have a Medicaid managed care case manager reaching out to her. Marcus could have the home visitor providing the asthma education, and grandma could have a diabetes self-education class to go to. When I was in Minnesota a few months back, one of the state folks I was talking with pulled me aside and said, I just had a call from a family the day before, and they had 15 care coordinators in their home last month and didn't want anybody to come back. So we're not being very family or person friendly when we're sending all of these care coordinators into a home. I'm going to come back to this family once we have the hub model in place to show you how things can be different. The foundations of the model are pretty simple. Again, it's find the right people at risk, do a comprehensive risk assessment, translate that risk into pathways, and measure everything that we do. I will show you a lot of paper forms, but in reality, we track everything through a tablet or through a cloud-based system. And I know on the call today is Bob Harnack, who's CEO of Care Coordination Systems. So if there are specific questions on data or technology, he'll be able to tackle those. So the workflow, when somebody is engaged in this model, all of the data collection is standardized. So the very first thing that's standardized is the release of information. So we're very clear on what kind of data we're collecting. Then we have a standardized client profile, which is all the demographics, an initial checklist, which is really looking at any kind of risk that person may be facing, and then ongoing checklists at every follow-up face-to-face visit. A risk that's identified is translated into a pathway. And pathways are unique in that they end in something that's a measurable outcome. So for example, if it's a medical home pathway, that pathway is not done until it's been confirmed that that person has shown up and done everything they need to do to become a patient at that medical home. This allows us to track every risk factor, whether it's a health-related risk factor or a social risk factor, through to completion. And in this model, completion of a pathway is tied to payment, and we'll talk about that a little bit more later too. The other thing with using pathways, and there's 20 standard pathways that are used, is that sometimes we don't get to the outcome that we want to achieve, but we're required in this model to track everything we did to try to get to the outcome so we can start to build the bigger picture of what's not working at the community or regional level. And this is a pretty powerful side of the model. This is just a listing of the 20 core pathways, and I'll talk about national certification towards the end of this, but just to give you a little bit of background, this model was selected by the Agency for Healthcare Research and Quality as their first learning network under their Innovations Exchange. So that meant that we had 16 communities from across the country meet over a period of 4 years that were all working on aspects of community-based care coordination. And what we found at the end of those 4 years is that folks that stuck pretty close to the foundations of the model were doing well, and those that had veered off and tried kind of variations of the model had not done so well, and most of those programs aren't around today. So the recommendation was we really need to put some standards around the model and bring it to a level of national certification. So after the Learning Network finished, we received funding from the Kresge Foundation, and we developed national certification that now lives at the Rockville Institute in Maryland. But these 20 core pathways are the key to the model, and they're really the only things that can't be customized in the model. So we can talk about that later as well. Once you are tracking everything in a standard way, you can compare. How are individual care coordinators doing? How are different agencies doing? How's a community or a region doing? And in Ohio right now, where we have 6 operating hubs, how is our state doing? You know, how are we doing with big measures around things like infant mortality and housing? This is our first published results around pathways, and this was actually pre-hub era when we were just doing pathways within our own agency. And we took 4 years of our data and we gave it to the Ohio Department of Health. They matched it to vital statistics, and then they gave that to the Ohio State University Department of Biostatistics. And what OSU did was develop case match controls by census tract, because we were very interested. We knew that there were areas of our county, again, where the birth outcomes were the worst. And what the study showed is if women were engaged with pathways, the low birth weight rate over those 4 years averaged out to be 6.1% versus 13% for the case match controls. And what everyone jumped to the conclusion was, oh, everybody in pathways was getting into care earlier and had way more prenatal visits. Well, the data didn't support that. There was no statistical significant difference in between entry into care or utilization of care But we knew with the women we worked with, on average, they had 5 additional pathways. And really, none of those were around healthcare. They were pathways with housing, adult education, employment, transportation, childcare, everything we think about with social determinants. When we started to see the impact of using pathways, the next step was to take it to a bigger scale. And so in our county in Ohio, we actually engaged all of the agencies that were working with high-risk pregnant women and put in place the standardized data collection and standardized pathways. Well, out of that evolved the hub, because now we needed a way to track what was going on within our entire network. And so the community hub is really that central point of organization and tracking of community-based care coordination. If Marcus was found and a hub was in place, his community health worker would first check back with the hub to make sure he wasn't already receiving services somewhere else, or that his family wasn't already receiving services. Because as we piloted this model, that was the first thing we found. There's a lot of duplication happening, and that's a waste of resources when we have way more people to serve than we have resources anyways. If the community health worker finds that no, Marcus and his family have not been found for care coordination yet, then she would do the standardized demographic intake. She would do the initial checklist, which is the comprehensive risk assessment. From that checklist, she would assign pathways. She would do regular home visits and work through the pathways to get to the outcomes. And when all pathways are closed, then Marcus and his family would be discharged from the hub. So if we go back to the family, you'll now see that the community health worker who's trained in this model realizes that everybody in this family is at risk and they all need services. So mom receives the initial pregnancy checklist, Marcus receives the initial pediatric checklist, and Mrs. Garcia receives the initial adult checklist. And they have, oh, are you still seeing my slides?
Nope, we can't see your slides.
Uh-oh. How long had you not seen my slides? Just temporarily, or?
Back. It was just a blip. You're back, thanks.
Oh, okay. Okay, great. So basically, so now everyone is entered into the hub as an individual. They all have had their comprehensive risk assessment, and they all have their own pathways to track and follow. So this actually puts structure for the poor community health worker that now has to keep track of all of the risks that have been identified. In the hub model too, because we have all of these pathways identified, we can take the funding from all of the care coordination resources in the community and braid that funding together at the hub level to really encourage one primary care coordinator with each person or family unit, because we don't need 5 different people working on transportation or 3 different people working on housing. We need one person that has enough time with that family to actually work on these big issues. That's not to say that somebody else can't come in and do very specific interventions around, maybe it's parenting or maybe it's, around asthma education. But to do the basic care coordination that family needs, there really only needs to be one person. And if you have a way to take that funding and expand it, then you can pay for one person to actually have the time it's going to take to work with that family. So just to be clear, distinctions between pathways and hub. Pathways are really the tool. They're the metric that's used to take any risk that's been identified, translate it, and follow it through to a measurable outcome. It is where the majority of payments in this model are tied to finishing pathways. So, and it's a requirement under national certification that at least 50% of payments be tied to outcomes. The hub, on the other hand, uses the pathways to track what's happening, but it's really set up as air traffic control. It is meant to eliminate duplication of services, to take the existing services that are already in the community and expand and grow them, and to provide a way to have funding that can be braided and support this holistic form of care coordination. The model's been around for a while, so it's certainly had some endorsers through the years. We just had a national summit in Ohio that was sponsored by the Institute for Healthcare Improvement and HRSA. The Agency for Healthcare Research and Quality has put out several publications on the model, so that's a great place to go for information. And I actually just came back from the CDC. There was a meeting out there around housing as a social determinant of health. When we implemented this model, just in its pilot form, just around pregnancy, we were able to show a county-wide drop in low birth weight rates from 9.7% to 8% within 4 years, while the state remained steady. And again, it wasn't rocket science. We were just getting everybody on the same page, tracking information in an organized way, and incentivizing people to find the most at-risk women in the community and make sure they were connected to the services that they needed. The more exciting trend for me is the impact we've made on health disparities. In Ohio, we're probably one of the worst states in the country right now around infant mortality. Our African American infant mortality rate is 3 times our white rate. In our county, where our hub's been in place for a while now, we actually may have a situation where we're seeing a higher white infant mortality than African American. Not that that's good, but we're making progress at least on one strata here. This slide is just to show the model can be replicated somewhere else. This is a partner hub in Toledo, Ohio, that's a very urban environment, and they have consistently shown low birth weight rates that are below 10%, while this county and the state continue to climb. They're above 14% now. There have been other hubs that have been established through grants up in Michigan that have specifically worked on adults with chronic conditions, and it was one of the original CMMI grants. They've reported a 50% reduction in per member per month costs within 18 months of implementing their hubs. So the key points around building a hub. The hub is neutral. The hub is a small entity that comes in or is an existing entity within a community or region. It cannot employ its own care coordinators. It has to keep that neutral status. There's only one hub in a community or region, and it must be present in the community or region. You don't want some hub from Ohio coming to run your hub in Washington. And the power behind the hub is really with the Community Advisory Board. That's a requirement that certification is very strong on. The hub is gathering all this data and is involved with contracting and other issues, but the decisions are made by the Community Advisory Board. This is just a diagram from one of the ARC manuals. Sure. Was there a question?
Sorry, no.
Okay, no problem. So this is just one of the diagrams from one of the ARC manuals, kind of showing, as you're thinking through building a hub, what are all the pieces and parts. So clearly, who's going to be the hub? But more importantly is who's going to pay for the pathways. So you need to have your funders engaged at the very beginning and figure out what their interest areas are and how many different funders you're going to need to bring in. And then clearly, what's our scope? How many care coordination agencies do we have that could do this type of work, and do we need to build up our workforce to be able to carry it forward? Pathways Community Hub certification is actually a partnership between CHAP and the Pathways Community Hub Institute that founded the model, the Rockville Institute, the Georgia Health Policy Center, and Communities Joined in Action. Again, they continue to be partners as certification moves forward. If you go to the Rockville Institute website, you can find all the information you need about applying or receiving technical assistance for certification. Again, they're going to require the use of the 20 core pathways. That's the non-negotiable part of the model. You can tweak pretty much anything else, any other forms of data collection, but not the pathways. And the reason is we've spent over a year in development of billing codes and modifiers so that we could kind of speak the language of the health plans. And so everything that we do within the hub, we can track and bill for using codes and modifiers that are understandable by the plans. So in summary, the hub model, the big benefits of the hub model is that it removes the silos and fragmentation that kind of plague the communities right now, and makes a more family-friendly approach to community-based care coordination. It's designed specifically to use existing community resources more efficiently and effectively. So again, we don't need to build a lot of new stuff. We've got some great things already out in the community. How can we use those agencies and that workforce better? It gives us, through the pathways, common metrics to identify and track risks, and more importantly, to track risk reduction. It gets us to a holistic or whole person community care coordination approach. It's sustainable. In Ohio, 4 out of the 5 Medicaid managed care plans currently contract with hubs for pathways. And we just renegotiated our contract with United Healthcare in Ohio to cover 17 of the 20 pathways. And it's owned by the community. So every hub in every community looks a little bit different, from who they decide that the hub is actually going to be to what the target focus is. It's just different across the country, which is really neat to see because it's very much built by the community. So with that, I will go ahead and stop and take some questions.
Okay, everyone. I'll just let you sort of self-manage your muting and unmuting with your questions.
Allison, this is Barry Kling. Could I ask a question?
You bet.
Well, Dr. Redding, first of all, thank you so much for this work. And it must be, you're really lucky to have such rewarding things going on in your career. It's just so impressive. But one aspect of it that I've heard some discussion of before I wanted to ask you about, and that is in braiding the funding, as you said. There are organizations that stand to save money when the hub works. Has that been a source of agreements up front in creating a hub that would then commit those parties to share some of the savings with the hub in order to keep it going? Is that part of the approach, or has it been in some of the places it's been used?
I think we're just hitting that point now with some of the hubs that have been around for a while. And it's always been the vision of the model is that as those cost savings appear, that there should be a portion that goes back to the hub, specifically the Community Advisory Board, to decide how to invest it back into the community, because who knows better than the folks that have been tracking what's going on and what's not working well. So that is a very ongoing discussion right now. It has not been totally figured out yet, though.
Well, if that hasn't been done yet, then where does the money come from to operate the hub?
So through contracts with health plans, through contracts with the state, through private philanthropy, through United Way. So a variety of funders.
Thank you. And it might be helpful to note for the ACH backbone leaders in that the outcome payments are each of those sources that Dr. Redding was referring to, but a very small percentage could be taken out of that to fund the overall hub operation. So I think that's an important sort of sustainability component to be noting.
That's a really good point. I mean, most hubs do need help with the initial infrastructure because even if you have contracts in place, you still have to get people trained and you have to get software in place and all of that. So there is that startup cost.
Hi, this is Alia from the Olympic Community of Health. My question is around accreditation. I was wondering if you could tell me what accreditation offers.
Sure. Well, it's important if you are going to contract with payers. So for example, in Ohio, our Medicaid managed care plans have agreed to only contract with certified hubs. And a lot of the push for certification, not alone, just from the model side, but the payers were saying, look, we like hubs, but every time we go to a community, they have a whole different approach and we don't know how to contract with them. So for them, it was just as important that we put some prerequisites and standards in place so that they absolutely understood what they were going to get if they contracted with a certified hub. And the danger is if you don't go kind of towards that process, you could have a bunch of hubs sprouting up all over the place. Certification actually allows for you to plant a flag in the sand and say, this is our hub for this region, and we're not going to build a bunch of mini hubs all around it because that's just more silos and fragmentation. The other aspect is a lot more research is beginning now around the hub model, and there's a network of the existing hubs that are partnering with that research, so you're part of that bigger community of learning and understanding what's working and what's not working well.
Hi, this is Kathy Tashiro from Pierce County ACH. Can you hear me?
I can hear you.
Okay. I have a question about, I guess it goes back to the cost savings. Is this similar to projects funded under the Medicaid waiver where it's pay per performance based on outcomes? Or is this, in terms of the payment and the savings, how does that work? I'm curious.
And so I'm not sure about the Medicaid side. I will just say, as the model developed, what we saw in the communities that we were working with is that there's actually a lot of resources and a lot of dollars, but there's not a lot of accountability. And so we kind of developed that side of it on our own within the model, that we wanted to hold ourselves accountable, that we weren't going to get paid until we actually made a real change for that person or that family. And it was a big struggle actually getting our funders to change contracts around outcomes, because we started this back really 2004, 2005, and that was kind of unheard of, that, wait, you're going to put more accountability and we don't have to pay you until you get this done. So it was a struggle at first getting funders to realize you can ask for outcomes, and if you ask for it, then people will probably figure out a way to do it. So we kind of were developing that side of the model on our own, and that's kind of everyone else is in that payment, value-based payment sphere now too. But it was just really part of the model development.
And so where do the cost savings go? Do they go back into the participating organizations, or how does that work, if there are cost savings?
Well, there are definitely cost savings, and that's kind of the earlier question too. But I think we're at that point in the model development where people are asking those questions. Mm-hmm. Because clearly, as if all the cost savings is going back to just the payer or just the state, then it's hard to grow the model bigger.
Yeah.
I think what's happened though is that there's a lot more money coming into communities through, in our state at least, through the Medicaid managed care plans that nobody had access to before. So it's been able to shore up, the safety nets within these communities. But it's a really good question, and it's an area that is really being looked at hard right now with the existing hubs, is how do we share in that cost savings, because we are saving quite a bit of money.
Mm-hmm. Okay, thank you.
This is Elisa from Pierce County, and I wondered if you had any examples of hubs that cared for patients that remained anonymous.
There actually is. We're piloting in our hub up in Toledo, Ohio. Toledo, for some reason, is an area of high human trafficking. And so we're working with the Human Trafficking Center there to be able to track and use use the hub, but to keep everybody that's within their program anonymous. So that's our first trial of that. It seems to be going okay, but the numbers aren't super big yet.
The reason I ask is that in our state we are, well, at this stage of the toolkit, we're going to be required to address the opioid use epidemic. And if we work with syringe exchange programs, many of those folks will remain anonymous.
Right.
So, and it's interesting to me because our model is most closely aligned with the domestic abuse or domestic violence model, and now the sex trafficking example that you have in Toledo. Thank you.
Sure, and we're actually we're partnering with Rio Arriba County in New Mexico, which has had, I think, the distinction of the highest overdose death rate for the past decade of any county in the nation. And so they're putting in a hub, and so a lot of these questions are coming up as they're ramping up to get their hub started.
Thank you.
Hi, this is Gina Morgan from the King County ACH. And my question goes back to the cost savings question that you were just addressing a moment before, just to make sure I understand how this works. So previously we were talking about how managed care plans have helped to pay for some of the startup and costs of implementing this. But as I understand it, they are not the ones who are realizing the cost savings. So I just was wondering what's in it for them. What's their motivation for signing up if they're not actually going to be the entities that realize the cost savings within their own businesses?
Oh, they do realize the cost savings because as they contract with a hub for their members, that they can certainly refer any member that they're concerned about to the hub, although most hubs do finding because we're better at finding than they are at identifying folks at risk. And they're paying for every completed pathway that happens. So the plans are invoiced on a bi-weekly or a monthly basis for any of those pathway completions that happen. And they're doing that because they're realizing the cost savings. The case in point was with United Healthcare that came back to us and said, what more can you do? Can you serve adults? Can you serve kids? Can you serve teenagers? And could you do more pathways? So we know they wouldn't be asking for expansion if they weren't realizing some cost savings benefit. And we knew that they had done a study earlier on, specifically around the high-risk pregnant women, that showed significant cost savings.
Okay, so maybe I'm not understanding the shared savings portion, because we were talking previously about shared savings. So
the shared savings hasn't really been worked out yet. So the way all of the hubs right now operate is that they contract with a payer, whether it's a health plan or with the state or with somebody like United Way, and those contracts state that they will pay for this number of completed pathways for the people in their sphere, so their members or whoever they're covering. So at this point, there's just a direct payment between the plan and the hub for the work that's done in a period of time. So at this point in time, there is no developed cost sharing strategy. That's what's being discussed kind of as we speak. Those are the conversations that are happening among the hubs at the national level now. Does that make sense?
Yeah, okay, that helps.
Okay.
Sarah, this is John Chapman. Can you expand on how the partnership between the hub and the care coordinators, like how they develop some of those contracts and how the hub decides what care coordinating company gets a patient?
Sure, and so we like to include everybody as much as possible. But there are some requirements in the standards that say what a care coordination agency has to be willing to do, and that is that they have to have a well-trained workforce, and that they have to be willing to use the data collection tools and the pathways and they have to follow, the hub decides how quickly that data needs to be in there, and there has to be a quality assurance piece to it. So any care coordination agency is welcome to join the hub as long as they agree to follow the requirements of the hub. And there is, as a hub is established, that's one of the first things that they do is set up their operations guide, basically following the basic standards, but then they have to fill out things like, how are we going to handle referrals? If we know that there are 10 agencies that are in this hub, do we just rotate through all 10 agencies? Do we decide based on a geographic area where referrals are going to go? And that has to be very clearly laid out and very transparent before they go through the certification process. And that's why the hub has to be neutral. There can't be any favoring, if they had their own care coordinators, the fear would be that they would give the best to themselves first. So all of that's pretty well defined within those certification prerequisites and standards.
Hi, this is Li Chi Liang. Is it possible to get a model or templates of those decisions for allocating clients to care coordinating organizations?
Absolutely. I mean, that's the one nice thing about this network of hubs through certification is that we share everything from, how we design our release of information forms to, what's worked as far as doing referral processes. Certainly through the Rockville Institute, they have all kinds of templates that can be used as you design. CCS has templates that can be used. It's a nice time to start up a hub because you don't have to do everything from scratch. I know that's kind of, trial and error in the old days, but most of it's been figured out now. Everything from contracts to you name it.
Sarah, could you make a couple of comments just in general about the trial and error that has occurred and sort of the belief that fidelity to the model and the things that there's a lot of flexibility we're finding in our deployment, but in the places that there aren't, can you just talk a little bit about why fidelity to the model is so critical and maybe some of those things that didn't work so that, as I like to say for our region, we're really interested in making new mistakes, not mistakes that other people had made.
Right. Yeah, don't do our mistakes. We did enough for you. It really was through that 4-year learning network. I mean, we watched some very big programs go down because they developed pathways that didn't really have outcomes, and they didn't, they would just kind of spin off and do other things, and that never ended well. And it was a real concerted decision to say because nobody likes to put standards in place and make things more rigid, but we really saw what happened when people were kind of left to their own devices and pick apart a model. And I think that's true of any model. I mean, if you're going to use a model, just use the model. Or if you're not going to use it, then develop something new. But to take pieces and parts, it just never usually ends well. Because the further you get away from the foundations of the model, the more likely things won't go your way. And so we tried to be really careful with not putting too many restrictions around it, and that's where we landed with the most important part of the model is the pathways, and the pathways are what's going to be standardized across all of the hubs. And that really allowed us then to develop those billing codes in a way to communicate that made sense, and it allowed enough freedom still with however you collect the other data through your demographics or your checklists or your other tools that you use, that you can get any kind of information that you want. It's just the pathways stay solid. And that really was, I mean, that was probably 8 years of watching things just not go well for programs that didn't follow the model.
Hi, this is Dawn Bonder in Southwest Washington with the Regional Health Alliance. I was wondering if you could speak a little bit to the technology infrastructure that's required to make the hub work with all of the agencies and others within it.
I can talk on a general level, and maybe I'll have Bob chime in with information about CCS. But it, as you can imagine, when you start connecting many agencies together and collecting all of this information, technology becomes critical. And actually, as part of our lessons learned, we probably tried 4 or 5 different data systems that we tried to get. We tried to take the existing system and make it do what we wanted it to do, and it just wasn't possible. So we were really happy when Bob came along and started Care Coordination Systems, because he helped us build from the ground up of really what we needed to have in place to make it work. So Bob, do you want to say a few words?
Hey, thank you, Sarah. Best thing I can say is what we found, and Sarah said it very well. When we tried to take legacy-based systems, it was definitely a square peg in a round hole. And if everybody's running different systems, the chance for standardization of the data across it and continuity, and probably loss of focus is another piece, exists when we don't have one system. Systems to us are tools, and the real innovation is in the Pathways Community Hub model and the care coordination effort. That's where the time should be spent, not maintaining technology. It should be working for us. That help?
Thanks, Bob.
The other thing that I would offer to this group is Bob and Alicia, thanks to a very significant and generous investment from Empire Health Foundation, have been building out the CCS technology platform for our pilot up in Ferry County. And I think either towards the end of this month, though, with all the holidays and so forth, maybe early in January, we'd be happy to host a both overview of the CCS technology platform, but then also very specifically how we are utilizing it here in Spokane, if that is of interest.
A few follow-up questions. This is Elia from the Olympic Community of Health. Does the care coordination systems interface with Epic? And is it the system that's endorsed by Pathways and needed for accreditation?
So let me answer the accreditation question first. No, you can actually do the Pathways Community Hub model on paper if you so choose, which I wouldn't advise. But clearly, certification is going to require, if you use a data system, that it's able to do everything that's required, which is to use all the 20 pathways, to track and report risk reduction, and those kinds of things. And honestly, right now, CCS is the only one that I'm aware of that can do that.
And Sarah, if you want me to answer the Epic
Sure.
question, seems to be a common question lately. Connectivity is probably one of the standing primary agendas within CCS. And by agenda, I don't mean vaporware. We actually already connect. We're actually connected to Maryland's HIE in a two-way model. We're connected to hospitals. We actually have also built into the system direct messaging, and I'm not sure if you're familiar with it, but through direct messaging, which was the government's interoperability standard between EHRs, CCS is now a direct messaging HISP. And it's integrated into the platform, so we're connecting through EHRs in that manner. There's also an API library, so if there were hospitals that wanted to create an Epic connection, we're actually in the process of discussions around Epic and some other EHRs in the process of creating the connections in other states. So those are things that are going to happen here very shortly to create even tighter connections. And it's really up to what we design, if that helps.
Yeah, that helps a lot. One quick follow-up question. Seems like you're the data guy. who owns the data, and can it be analyzed locally?
Yeah, actually, the data is owned by quite frankly, owned by the client. All right, it's there for the social determinants of health information. The hospitals own their clinical data and their claims data. The hubs don't own any data in this process. They're really facilitators to help people get to better health in the process. What we ask is we execute BAA agreements, both from the hub and from the CCS perspective. And in those BAA agreements, there are research clauses that say, hey, we want to use the data in de-identified status and to create research opportunities and better innovation in the pathways model. Does that help?
Yeah, thank you.
And does that envision the hub being a HIPAA compliant entity in order to obviously execute the BAAs, correct?
Yes, actually, it is a requirement that they are, yeah.
Right, thank you.
Hi, this is Kathy Tashiro again. I was very interested in what you said about the Community Advisory Board for the hub, that that's where the power resides and they make the decisions. And so could you say a little more about what kinds of people might be on the board, an example perhaps of the kinds of decisions that have been made? For when I say what kind of people, are they actual users of the system? What level of community are we talking about, and how does that function in practice?
Great question. And so again, that's up to the hub to decide, but there's the standards push them towards having involvement of certainly community members, from the community-based care coordinators and the agencies that employ them, from funders and other key stakeholders within the community. And sometimes that's set up more as a core group with advisory, kind of a core advisory group with a larger advisory arm to it, where people can meet, on a less regular basis. But the more involvement, the better.
Mm-hmm. So it sounds like you're talking about people who might have close contact with the actual users, but are there any that have users of the services that are on the community advisory boards? It's something we're looking at Pierce County ACH in terms of our community engagement plan. That's why I'm asking.
It's actually a requirement that they do have community folks on the community advisory board. So if they're a certified hub, they have to have folks from that are receiving services participate.
Right.
And then in Southwest Washington, and I have a question around the community health workers. I was wondering if you could talk a little bit more about their training, their background, and just a little bit more about their role, their scope. Is it all individual based? Is there opportunity for impacting policy systems, maybe through that community advisory committee? Love to hear a little bit more if that's possible.
Yeah, so I can certainly give you the Ohio perspective. So, again, Ohio has the certified training. So I believe there are 12 training sites in Ohio, and they have to be, go through a procedure to be accepted as a training site. And in Ohio, there's a statewide Community Health Worker Association, which I think is critical too. If you're going to have the training, you need to have a professional way for them to meet on a regular basis. With what the hub certification requires is a minimum level of training if you're using community health workers. And so in some states where we've put hubs in where there isn't as structured of a way to train the workforce, we can do a crosswalk to kind of see what training they've had and where we can just kind of patch in maybe some training that's missing. So there's states that have great training, like Minnesota, that are just ready to go, and others that really have pretty minimal standards or training requirements. So it's kind of a case-by-case basis. But really, the more training, the better, and not just the community health workers, but the supervisors. And that's kind of the magic glue. You can have great CHWs, but if the supervisors aren't well trained, you're not going to have a very effective program. So we emphasize a lot of training and a lot of training around just how to use the pathways and how to kind of think that way and to track what's going on once you're within this system.
Wonderful. Thank you so much.
Sure.
We have a comment from Bethany at AmeriGroup. How will rural providers and agencies in multiple counties connect to the hub if they don't have the infrastructure or capability to take on that work? And I would add to that, there's both the sort of community infrastructure piece, but in some of our rural counties, at least in our area, there is some less than consistent internet access as well. So as we look at a cloud-based infrastructure, how does that play out?
Well, the nice thing with Bob's system is that his tablet design doesn't have to connect to the internet, so you can actually do all your work and sync it up later. I think with rural areas in particular, clearly you don't want a hub in each county if they're really a rural area. You just want a hub for a region because really, again, they're just tracking what's going on. Part of what might help with the hub is to identify all the things that really are missing. It's not like putting a hub in place is going to all of a sudden magically make everything better if it's not there to begin with, but it will give you the way to track how bad it may be in some areas and how long it might take to finish a pathway for somebody that's in a very rural area that it may take them 10 times longer than somebody in a more urban area. So if anything, it starts to give you the power of the data behind, you keep saying that things aren't there, but nobody quite takes you seriously. When you start having solid data behind it, it's a lot harder to ignore.
Are there other comments? I want to draw everyone's attention to Marianne, who helps coordinate some of our community health worker network activities here in the region, where there is a monthly meeting for community health workers and stakeholders already in place that may exist in other regions as well. And I would encourage my ACH colleagues to, as you're contemplating this, thinking about how there is already infrastructure in place and that this is really designed to be a value add, not a takeover resource. Are there other questions? I don't want to keep us on the line longer than we need to, but I don't want to miss out on this opportunity for folks to ask Dr. Redding any questions.
I have one last quick question. This is Elisa and Pierce. Have you had any examples of areas where there's a pretty big divide between clinical community health workers and non-clinical community health workers, and how those standards are established if you've got that kind of a divide?
I haven't really seen that. I mean, we certainly have community health workers that are embedded within the healthcare setting and ones that are totally out in community-based settings, but both can use this approach and it seems to work for them. So I've not really experienced that.
Okay, great, thank you.
Sure.
Any last comments?
And certainly if folks do have questions, I know Allison and Alicia have my contact information. I'd be happy to answer questions later on too.
And if we wanted to have questions to care coordination systems, would that be to you, Sarah, or your colleague that we heard from earlier?
To Bob, and they have
Bob.
his contact too.
Okay. Allison, can you push that out for us?
You bet. I will add, I will send out to everyone who was on our invite list and several of you who have emailed or through the chat function said you'd like the slides, and include both Dr. Redding and Bob at CCS's contact. And I can't help but give just a shameless plug for how heavy a lift Alicia has taken in our region, and really playing off her experience in Central Oregon and her deep knowledge of what's happening with both the ACHs and the Healthier Washington transformation work. So she's also just a really excellent resource for anyone to tap into, certainly with her EHF health strategies hat on. Okay, with that, if there are no final questions or comments, I will let everyone get back to their Friday, and hopefully you can finish out strong and get some holiday cheer this weekend. We look forward to seeing everyone soon.
Thanks, Allison, for organizing this.
Hi, everyone.
Hi.